This PowerPoint will review wrist and hand anatomy and discuss common conditions with clinical application. This slide reviews the carpal bones of the wrist. They are listed from proximal row to distal row and from medial to lateral. Reminder that medial and lateral direction is determined from the anatomical position. So in the anatomical position, arms are at your side and you are in a fully supinated position. Carpals that I want you to pay close attention to for this course would be capitate and triquetrum. Both of these will be areas that we will palpate and align a goniometer for measuring wrist range of motion. If you take notice, you can see that capitate articulates with the third metacarpal. So if you palpate down along the metacarpal, I guess going more proximal, and then you at that joint you will feel capitate. If you move your wrist into flexion and extension, you will feel capitate as you flex your wrist to pop up under your finger. And then triquetrum will be right at the base of your ulna. So if you palpate your ulna distally and right at the end, you will come in contact with triquetrum. So take a moment and palpate both of these carpal bones. Here we have the carpal bones displayed along with the bones of the hand, the 5 metacarpals and 14 phalanges. As a reminder that the thumb or the first digit only has a proximal and distal phalange and does not have the intermediate phalange. The articulation at the wrist consists of the radiocarpal joint, which is the radius articulating with scaphoid and lunate. There is actually a disc that is at the distal end of the ulna, and so that the actually ulna does not articulate with the carpal bones. As we look at the arthrokinematics of the wrist joint, you can see that the proximal row of carpal bones, if we look at them as a whole, are a convex surface moving on the concave surface of the radius and ulna. And so we have convex on concave, so they are moving in opposite. You must remember that as we talk about the glides and the movement, that we are doing it from an anatomical position. So go ahead and place yourself in anatomical position and go into wrist extension. So in wrist extension, the roll will be posterior and the glide is anterior. So if you wanted to improve through joint mobilization, you would do an anterior glide. If we do the opposite, so if we do flexion, our roll is anterior and our glide is posterior. So to improve range of motion, we would do a posterior glide. And it's the same for both. As you'll see that the distal row of carpal bones also make a convex surface, and so those same rules apply. This slide shows the 5 carpal metacarpal joints and the specific articulations of which metacarpal articulates with each carpal bone. Before discussing the joints on this page, I want to revert back to the carpal metacarpal joints discussed on the previous slide. There is minimal movement of flexion and extension through the 2nd through the 5th digit. And we won't even measure this range of motion in class or in the clinic. But the first digit at the thumb, the carpal metacarpal joint, is where it actually has the ability to move flexion and extension, AB and adduction, and then a combination of flexion, abduction, and pronation or medial rotation to form thumb opposition. We will review these directions in class because it goes counterintuitive, but if you want to practice right now, go ahead and put your palm face up. And if you were to bring your thumb along the base of your palm in the frontal plane, that is actually flexion. And then if your thumb is to come out like you're hitching a ride in that frontal plane, that is extension of the carpal metacarpal joint. Whereas if you put your thumb directly in the palm of your hand and you bring your thumb away from the palm, moving in the sagittal plane, that is abduction, and back towards the palm is adduction. So that's different than the other joints in the body, so we will review in class. But now moving on to talking about the MCP, PIP, and DIP joints. MCP is your knuckles, so that's your metacarpal phalangeal joints. They all have 2 degrees of freedom where they can move into flexion and extension and radial and ulnar deviation. The PIPs are between the proximal and middle phalanx. So you see that the thumb does not have a PIP joint, it just has an IP joint since there's just the proximal and distal. Motion at both of these is going to be flexion and extension. And you can see that in the picture that you are going to have concave moving on convex. So that means that both move, the roll and the glide move in the same direction. So if we are talking about finger flexion, the roll and the glide is going to be in an anterior direction, and so would the joint mode be to improve. This slide is for you to take time to review the anatomy. Please be able to state each of the joints and the carpal bones as they are listed. The ligaments at the wrist conclude the volar or palmar radiocarpal, which you can see in the picture, the dorsal because it's on the other side, you cannot, and then the ulnar and radial collateral ligaments. Also know that as you go through the hand and the fingers at the digits, that there are collateral ligaments at the MCP and the PIP and DIP joints, both radial and ulnar. And then there is also a transverse ligament that goes across all 4 of the MCP joints, so digits 2 through 5. This is a review slide of each of the motions for the wrist, the carpal metacarpal joint at the thumb, the first digit, the MCP joints, the PIP, and the DIP joints. Please review and feel comfortable, as well as the arthrokinematics at each of these. Take a moment to review the muscles that make up the thenar and hypothenar eminences of the hand. Take a moment to review the lumbricals And the interossei muscles, what motions do they perform? Go ahead and take a moment and do the lumbricals and then interossei. Our wrists and hands have lots of joints and movement and are responsible for doing both gross motor and fine motor control. They have great blood supply and nerve distribution. So when there is an injury to this area, it can be a nerve injury at the nerve root, so somewhere originating in the cervical spine, or maybe some type of entrapment or through trauma and cutting of the nerve anywhere between that pathway of the cervical spine and where it innervates that muscle. Our thumbs, because of the ability to oppose, account for about 40% of the hand's function. There's a reminder of the two joints of the wrist. We'll talk more about the carpal tunnel when we talk about conditions, but as a reminder, the carpal tunnel is set up by the carpal bones, and then there's a transverse ligament that's more superficial, and in between there's the tunnel. And so what travels in the tunnel? Well, we have the median nerve and all of the flexor tendons. So when there becomes irritation of this area, we'll discuss that in an upcoming slide. And then there at the bottom is the picture of the capitate or Darth Vader, some people like to call it, and knowing that it is the center of rotation of the ulnar and radial deviation for the wrist. In function, our hands and wrist do not maintain a neutral position of 0 degrees. Anytime that we go to use our hands, say maybe you have a drink sitting next to you, go ahead and pick up your glass of water or whatever it might be, and you can see that anytime you go to use your hand, there is going to be movement at each of the joints. Listed above shows you what is required for most functional positions, and it's called a functional hand, so that if you have this amount of motion at each of the joints, you should have functional movement of the hand and be able to do activities with it. So you see each of those listed up there. The picture is a functional hand splint. So if there is some type of maybe nerve injury or some type of injury to the hand or wrist, they can be put into this type of splint to maintain a functional position, so that if they're immobilized, that they don't lose all of their range of motion. This also splint could be used for those after they've had a stroke, and maybe they have increased muscle tone, and so this can help to maintain. So if you've ever seen anybody who's had a stroke and maybe they have contractures of their upper extremity and you see that the wrist is all flexed and drawn in, sometimes these splints are used for prevention. Here's a reminder at the top that the power or the gross motor function come from the extrinsic muscles, so that would be the wrist flexors and extensors that attach to the medial and lateral epicondyle, and the fine motor control comes more from the intrinsic muscles within the hand. Some grips that we should talk about, some for power, would be the hook, and you see briefcase listed there. So if you have your hand down at your side and imagine that you are holding a briefcase, so that's the hook grip. The fist, I don't think that needs explanation. The sphere, so think about if you're holding a softball or a baseball, that's the sphere grip. And then the cylinder, I think of the ice pick, and the only time when we think of ice picks, just in scary movies, is, well, at least that's when I think of it, but that idea of the ice pick grip, as if they were going to, be chopping at a big block of ice. Then for more precision, we have the lateral, which is as if you use your key to unlock your door, how you place it between your thumb and your second digit on the lateral aspect of the second digit. And then there's the tip to tip, which a pincer grip. So doing your between your thumb and each of the digits, that's tip to tip, or you can actually do pad to pad. So the whole kind of distal phalange would be pad to pad. And then we have digital prehension, or people will call it the three-jaw chuck. And this is the thumb between the between the thumb and the second and third digit, often how we hold a pencil, although we'll have to check out everybody's pencil grip. And then, as we talked before, there can be nerve damage, which will definitely limit a patient's function. There are 3 nerves that supply this area. The median nerve, which is going to be on the palmar surface, the first digit, second, third, and halfway through the 4th digit, and through the palm of the hand. As we talked about, it travels through the carpal tunnel, so that is a common site for entrapment or irritation. The radial nerve, which is going to be along the dorsum of the hand, is what it supplies sensory-wise, and motor to the extensors. It can have entrapment at the radial tunnel at the elbow. And then the ulnar nerve, which is going to be the 5th digit and half of the 4th on the palmar surface. And a common site for entrapment or irritation is the cubital tunnel at the elbow, or Guillaume's tunnel at the wrist. The link on this slide is for a video that shows a neuro assessment of a hand to know if there is any entrapment or damage between the median, the ulnar, or the radial nerve. I have placed this video under Module 2 on Blackboard so that you can either pause right now and take a look at it, or watch the video after you've completed the PowerPoint. You see listed several deformities depending on what the result of the injury. So whether it's a neurological injury, if it's something due to arthritis, if there's a tendon injury, or there's an other as well. So take some time, and I do want you just to look through your textbook by Shankman and Mask and look at some of those conditions. And also I have attached a Word document to Module 2 on Blackboard that shows pictures of some of the others that might not be seen in the textbook. We will now review some common clinical conditions of the wrist and hand. Sprains to the ligaments in the hand and digits can often occur if there is a fall onto an outstretched hand, or maybe during recreational or sports activities. This can definitely impede someone's function. You see there that it is also typical a varus or valgus stress. Does everybody remember what that type of stress is? If not, we can review that in class. It does list on the PowerPoint slide that the ulnar collateral ligament will prevent a valgus stress, or would slow down that direction of pull. However, this does change midway through the palm of the hand. So yes, that is true for digits 1, 2, and 3, but digits 4 and 5, it is in the opposite direction. So I don't want you to get hung up with varus versus valgus stress. Just know that it is that lateral stress that could cause a sprain in either the ulnar or radial collateral ligament. A sprain can occur to the ulnar or radial collateral ligament at any digit if enough force is applied. A specific injury is called skier's thumb, or also called gamekeeper's thumb, and this is involving the ulnar collateral ligament at the MCP joint of the first digit of the thumb, and may involve the IP joint as well. So it's going to be a force of a valgus force, and often hyperextension of that joint as well, and it's going to be a sudden force, so a sudden valgus or hyperextension force that will cause a sprain in the ulnar collateral ligament. You see a review of the grades for sprains. Again, grade 1 is going to be a stretch on that ligament. We are not going to see these patients. They're going to heal on their own. And then a grade 2 would be that there is going to be a partial tear of the ligament. This can be immobilized for about 2 to 4 weeks, and then once given clearance, it would begin with passive range of motion and then progress to active range of motion resisted exercises. Again, we will always use our modalities as needed to decrease inflammation or to even increase the tissue temperature so that we can improve range of motion if there's been any limitations due to immobilization. And then a grade 3 is going to be a complete rupture of the ligament, and this will require surgery for repair. They will be immobilized for 4 to 6 weeks, and then it's going to be the same progression after removed from the cast or the splint. This picture shows the mechanism for injury for the skier's thumb or the rupture of the ulnar collateral ligament at the MCP joint of the thumb. Again, it's also called gamekeeper's thumb as well, same injury. Here are some examples of exercises following a ligament sprain of one of the digits. You can see that the patient themselves, the top picture, can complete passive range of motion on themselves as part of their home exercise program, and then progress to just doing some active range of motion, whether it's making the fist or going into full finger extension. And then you can add some strengthening, so whether they're picking up objects or gripping, these could be weighted objects as well. Fractures to the hand can occur within the metacarpals or in the phalanges. There are 2 specifically named fractures if they occur in the metacarpals. If the fracture is in the 5th metacarpal, it is a boxer's fracture. Consider with the mechanism of injury of doing we'll say, cross hook or a jab. So the fracture of the force will be within that 5th metacarpal. Bennett's fracture occurs at the metacarpal for the 1st digit or the thumb. And then if it's within the phalanges, there is not specific names other than stating a fracture of the 2nd proximal phalange or whatever its exact location is. The picture on this slide is showing a fracture of the 1st metacarpal, so this would be a Bennett's fracture. And then it's showing you surgical pinning. So these fractures, depending on their severity, can be treated with a closed reduction, meaning setting it in place and immobilization in a cast. Or if it is severe enough, the surgeon may choose to do an open reduction internal fixation, which is what you are seeing the pinning on the other picture. But either one, depending on following in the immobilization process, then we are going to progress with other fractures from passive range of motion, active range of motion, and then into strengthening exercises. On this radiograph, we can see several fractures. Probably the most obvious, we see the boxer's fracture of the 5th metacarpal. And then you see a fracture at the distal end of the 1st metacarpal. So this wouldn't necessarily be called a Bennett's fracture because that is the more proximal end of the metacarpal, but there is definitely a fracture there, as well as at the 2nd distal end of the metacarpal of the 2nd digit. In this picture, we are seeing a cross-section of the carpal tunnel. You can see each of the proximal row of carpal bones labeled, the transverse ligament, which is going across the top of the tunnel, and then you can see the cross-section of the flexor tendons and the median nerve traveling through the tunnel. Carpal tunnel syndrome occurs when the tendon sheath of the flexor tendons becomes inflamed is what we call tenosynovitis. And as it becomes inflamed, there can be some edema or swelling in the area, and it is a very restricted space, so the patient can develop numbness and paresthesias, or numbness and tingling in that median nerve area. So if the inflammation is great enough that it then compresses the median nerve, that's when we're going to see these symptoms. You can also see, depending on how long this has been going on, you may see muscle atrophy of the thenar eminence, which is supplied by the median nerve. The mechanism of injury for this condition is usually an overuse or repetitive movements. So a lot of maybe factory worker, somebody who's doing a lot of wrist flexion, keyboarding. Also, it occurs when people have something with vibration. So whether it's using power tools or a jackhammer or anything of that can cause that irritation or inflammation. We can do positive signs beyond what is symptomatic. We will review these tests, these special tests in class. We can do a Tinel sign, and then there's also the Phelan's and reverse Phelan's that, if we're positive, would lead you to believe that the patient has carpal tunnel syndrome. Clinical management for this condition would be able to give that person rest from that repetitive motion. So whether they can continue their job but maybe be wearing a splint that will support them more in that resting hand position and not in that flex position. The physician may give them anti-inflammatories or NSAIDs. If it's not with rest and doing some physical therapy to decrease the inflammation, if that's not successful, the physician may do steroid injection, or the patient may even require surgery where they will go in and release some of that transverse ligament so that it increases the space in the area. If a patient does have surgery, it's going to be similar to any time that we are treating patients after immobilization. We'll be doing, passive and active range of motion of the wrist and the digits. We're going to try to decrease their edema, because even after they've had surgery and that area is trying to heal, that edema itself could cause more compression on the median nerve. We'll be doing soft tissue massage so that there isn't any, as it's healing, it's not going to bind down. We'll make sure we continue and keep that range of motion. And then we'll work to doing some strengthening and also really talking to them about the function of their job or their position, and if there's any modifications that can be made. These pictures are showing the median nerve distribution, and it does cover from the first digit of the thumb until halfway through the fourth digit. De Quervain syndrome is tenosynovitis of the abductor pollicis longus and extensor pollicis brevis. This can come again as an overuse syndrome or with a stress of combination of movements of wrist flexion, extension, radial and ulnar deviation, as well as thumb abduction and extension. Whenever you're gripping something with ulnar deviation. And I think how it was originally named washerwoman sprain, it gives you a good idea of those combinations of movements. So thinking about wringing out the clothes so that all of that flexion extension with ulnar and radial deviation occurring, as well as the abduction of the thumb. Signs and symptoms is that the patient will have pain and tenderness and swelling over that area near the radial styloid. They're going to have difficulty with doing any type of powerful grip or lifting up anything. Their pain may radiate proximal or distal. You may see actually a loss of motion within thumb abduction or abduction. Sorry for that. And then you'll have pain with resisted extension. And you may see some thickening of the tendons that are involved. The test that we can do for this is Finkelstein's. We will do that in lab this week. So what is the clinical management for this? Any activity that is caused by overuse is going to be needing rest and activity modification. They can also be put in a thumb spica splint so that they can rest, usually for 6 to 8 weeks. The physician may prescribe NSAIDs or give a steroid injection. And therapy would want to use modalities to decrease the inflammation, so whether it's cryotherapy, phonophoresis, or iontophoresis. And then we'll do active and passive range of motion within a pain-free motion, and then progress to strengthening exercises. Dupuytren's contracture is a result of overactive fibroblasts that lay thickening or contracture of the fascia on the palmar surface of the hand. Often it'll be on the ulnar side, and like encompassing the 4th and 5th digits. We often can see it too occurring in the feet, in the plantar surface of the feet. Usually the onset is insidious and painless and takes a long time to develop, can even take years. It's often seen more in men over the age of 50. It can also be a result of just scarring. Maybe there was a traumatic cut or injury within the hand, and then as the scarring occurs, patients can also develop this contracture. So what is the clinical management? More conservative management would be doing dynamic splinting. So a splint that's going to put constant tension on that area, and hopefully be able to increase the range of motion or stretch that out. Patients may also need to have a surgical release where they go in and the surgeon will break up that contracture and that scar tissue. After surgery, patients will begin with passive range of motion and progress to active range of motion. They may still be, while they're in therapy too, is to have a continuing splint to keep them into extension, because it is a normal resting position too for our hands to be in a more flexed position, which would just encourage that contracture to reform. So putting them more into extension, as well as having them on a very active home exercise program so that they are continually stretching that area and not allowing the contracture to reform. Wrist fractures, mechanism of injury is often what we would call a fouche injury, a fall on outstretched hand. Now, if the wrist is in an extended position when they fall, it is called a Colles fracture or a silver fork deformity. And we'll have pictures of that coming up. And the silver fork deformity is just that it looks like a dinner fork. When it is falling on, it is going to be a fracture of the distal radius for both the Colles fracture and the Smith fracture. It's just the mechanism of how the fracture occurs and the direction of the displacement of the fractured bone. So if the patient falls on a flexed wrist, that is called a Smith fracture, and the displacement of the bone will be towards the palmar surface of the hand, versus in a Colles fracture, it will be into the dorsal surface. Also, on a fall, a patient can have a fracture of the carpal bone, and the most common fracture is the scaphoid. It is more prevalent to have wrist fractures in our older population, or even beginning at age 50. Sometimes the ulna is also fractured, but it is a lot of the force is going to be at the radius at that joint, and that's where we consider it a wrist fracture. The clinical management, depending on the severity, on whether the fracture can be reduced with a closed reduction or require a open reduction and surgery to stabilize the joint. And then, of course, the patient will be casted and immobilized. After the immobilization, we'll be working to control any inflammation in the area or edema with using our modalities, and then work on progressing mobilization with passive and progressing to active range of motion, and then working on strengthening exercises and gripping exercises. And then towards the end, we know when the fracture is totally healed, we'll be doing more aggressive stretching and strengthening, and also in weight bearing. Something to be aware of is that complex regional pain syndrome can occur following this type of injury, and that is a sympathetic response to pain that is not normal. They will have increased pain in that area. They will have changes in the skin and decreased hair. They'll be very, with slight touch, even like clothing on that area could cause complaints of pain. It was just used to be called reflex sympathetic dystrophy, RSD, and you may hear me refer to it since I am old school. We can discuss that more in class. Here is showing the mechanism of injury for the Colles fracture on an extended wrist or the Smith's fracture on a flexed wrist, so that you have that visual. Here's another picture of a Colles fracture. You see the palmar view where you can see that also the ulna is involved in this fracture, and then you can get the real view of the silver dinner fork deformity when you see the lateral view of the Colles fracture. Again, this is a fall on an outstretched extended wrist. We will be learning manual muscle test, range of motion, and special tests for the wrist and the hand during lab.